Good evening, good afternoon, and good morning. This is the 1572nd day of uninterrupted webinar conducted by International Forum for Promoting Homeopathy. Today, our guest is Dr. Krishna Parikh. Let us begin the session with 1 minute silent prayer. Thank you all. The International Forum for Promoting Homeopathy comprises of homeopathic lovers, students, and doctors, and we have 3 sessions every day. The first session of the day is already over in Hindi from 7:30 to 8:30, and from 8:30 to 9:30, we have an international session in English, and from 9:30 to 10:30, we have a local language session in Malayalam. All these sessions are going in a good way, and we are uploading the videos of the same on the very next day itself, so that those who misses the session can watch it again, and so without paying a penny. That is the beauty of our forum. The purpose of International Forum for Promoting Homeopathy is to take homeopathy to every home around the world. And we have participants from 65 countries in these sessions, and they have made different presentation, not only homeopathic doctors, but also eminent personalities from health and other field. So let us come to today's session. Our guest of the day is none other than Dr. Krishna Parikh. She has completed a BHMS and a Diploma in Naturopathy and Yoga from MG University, Delhi, and is working as an assistant professor, Department of Obstetrics and Gynecology, Sri Mahalakshmi Mahila Homeopathic Medical College. And she has more than 22 years of experience in teaching as well as in clinical field, and possessing a strong foundation in homeopathy principles and specialized expertise in obstetrics and gynecology. Her commitment to holistic healthcare is further enriched by her qualification in naturopathy and yoga. She is also a skilled communicator with the experience in broadcasting, provide comprehensive homeopathic care to women, including pregnancy. This is all about she is a person, she always talk very beautifully for homeopathy at different forums, and not only in here. She used to talk in radios, TVs, and everywhere. Anyway, congratulations, Dr. Krishna Parikh, for joining the session, and I proudly welcome you for as well as the participant for this a wonderful evening. And today, Doctor will be discussing about pelvic abscesses, understanding along with its homeopathic management. As we all know that lot of cases are coming with the pelvic problems. So let us see what are the things Dr. Krishna Parikh has to say about this and how it can be managed with homeopathy. Welcome, Doctor.
Namaste, everyone. Myself, Dr. Krishna Parikh, and I would like to thank the team of IFPH, Informative International Forum for Promoting Homeopathy, for giving me such a wonderful opportunity. And namaste and good evening to all the doctors who have joined this meeting. And I would like to start my topic. My topic is pelvic disorder, pelvic abscess, understanding, and along with its homeopathic management. So let's start. I would do the slide presentation, and
Yes,
then we will go with the along with the slides. Okay. So my topic, that is pelvic abscess, understanding along with its homeopathic management. So firstly, what is pelvic abscess? So we can say as we know, that is the pouch of Douglas. Pouch of Douglas, that is the recto-uterine pouch, or you can say that is the pelvic peritoneal fold of the cavity which lies between the uterus and the rectum. That is the recto-uterine pouch, as we know as the pouch of Douglas. So there is encysted pus collection in the pouch of Douglas, which is termed as pelvic abscess. If we will move further, then there is a difference between phlegmon and the abscess, and the main difference you can see here in this region, that the phlegmon, that is the abscess that spread through the tissue and the muscle fibers, while the abscess which contained within the wall. We can see here in this image that that particular pus or the abscess has covered the pelvic region along with the adhesion with the small intestine. If in the initial stage, if it is not covered or the recovered or the treatment is not given, then the adhesion starts along with the adjacent visceras. So this abscess has called the adhesion along with the small intestine. If we will move, the phlegmon is an infection generally treated by the antibiotics only. Generally, phlegmon doesn't require any drainage, while the abscess that required the drainage. So one can drain this abscess. Okay, now the etiological factors related with this abscess. So it may be pelvic causes which are common and the extra pelvic causes which are very rare. If we say the pelvic causes, it may be post-abortal or the puerperal sepsis, or it may be acute salpingitis. Right now, I am listing just the causes related with the pelvis or the extra pelvis. Later on, I will show you the image or the slides regarding the same. So, the pelvic causes, it may be after abortion or after puerperal sepsis, any pus formation which takes place into this rectouterine pouch, or acute salpingitis which may occur. Acute salpingitis may occur because of the ectopic pregnancy. And this ectopic pregnancy, which can lead to such condition, perforation of an infected uterus, such as attempted uterine curettage. As we all know, DNC, that is dilata and curettage, that is the procedure which is a blind procedure. One doesn't know how much we should insert that particular instrument, that is curate. So it can lead to the perforation of the uterus, and one doesn't know about this perforation because the viscera doesn't have any kind of any pain. Next, that is the infection of the pelvic hematocele, which usually following disturbed tubal pregnancy. Then post-operative pelvic peritonitis following abdominal or vaginal operation. If we have done any instrumental surgery per abdominally or per vaginally, so because of that, organisms may enter. It may be streptococcus or it may be staphylococcus aureus, and which can lead to some infectious condition into the pelvic region. Most important thing in this, the pouch of Douglas, which is the most dependent part into the pelvic cavity. As I regularly say my students that this pouch of Douglas, according to the, if we think about the gravity, then each and everything which falls, and this is the most empty space and most dependent region into the uterine cavity or pelvic cavity, sorry, not the uterine cavity, into the pelvic cavity. So each and everything which comes or falls in this cavity, that's why it is the most dependent part. So we can say, now the next cause, that is the irritant peritonitis following contamination of urine, bile, vernix gaseosa, meconium, which may be spilled during the cesarean section, iodine containing dye, which may use into the acid hysterosalpingography, or contents of the ruptured ovarian cyst. So these are the listed pelvic causes which are common for the pelvic abscess. Now, there are some extra pelvic causes which are rare. So appendicitis, diverticulitis, ruptured gallbladder, perforated peptic ulcer. So these are the list of the conditions which can lead later on the pus formation, and this pus is tracked down into the rectouterine pouch it is collected in the rectouterine pouch, and then we can term it as pelvic abscess. Generally, what happened, what I tell my students, that the pelvic abscess, you can say it is a clinical symptom. So cause lies somewhere else, whether it may be pelvic cause or it may be extra pelvic cause. So one has to find out the cause first, and according to the cause, the treatment is given. Okay, next slide. As we discussed about right now, the causes. So this is the image of the acute salpingitis. You can see here the inflammation of the fallopian tube. Next one, that is the pelvic cause, which is post-operative pelvic abscess. One can see here the collection of the pus, as well as there is adhesion of the small intestine with the uterus. So adhesion takes place. Here, there is pelvic peritonitis. Here I tried to show something inflammation related with the peritoneum. That is the pelvic cause and pelvic peritonitis. Tubal pregnancy. You can see here that the tubal pregnancy can occur ischemic region, intestinal region. So disturbed tubal pregnancy leads to the rupture of this fallopian tube. This ruptured fallopian tube can cause the infection and infection of the pelvic hematocele, which may lead to the abscess formation. And abscess formation, this abscess is collected into the pouch of Douglas. Here, one more cause, that is the uterine perforation. Right now, I said that is the here. If the instrument is inserted in this arrow manner, then it can lead to the posterior perforation. And here, if the instrument is here, it is anterior perforation. Why? Because this one is the anteverted uterus and this one is the retroverted uterus. Sometimes what happened in the condition, if the conditions like uterine fibroid, if the fibroid is bigger or multiple fibroids are there, then the anteversion of position of the uterus may be converted into the retroverted position of the uterus. So one doesn't know that the uterus position is converted from anteverted to retroverted. And at that time, if the DNC is performed for some clinical condition, at that time, there is perforation can occur. Or uterine curettage in septic abortion or pyometra. Here are the types of the uterine perforation. You can see here. It may be lateral perforation, fundal perforation, posterior perforation, then lateral perforation. You can see here anterior, posterior. So sometimes it may require some prostoscopy or lateral perforation should be evaluated for bleeding due to nearby uterine vessels and broad ligament hematoma risk. So this is one more pelvic cause. These are the extra pelvic causes. One, that is the appendicitis, which can cause the general peritonitis and which can ultimately settle into the pouch of Douglas. You can see here. One more extra pelvic cause, that is the diverticulitis. Here you can see the diverticulosis and diverticulitis. That is the inflammation of this large intestine. It also produces the general peritonitis. Next slide, that is rupture of the gallbladder. You can see here the types of rupture. Here type 1, type 2, the different types of the rupture of the gallbladder. So it can lead also general peritonitis and condition it may settle to the dependent pouch of Douglas. Now, what are the clinical features related to this? The clinical feature That is, there is spiky rise of the high temperature with the chills and rigors. There may be rectal tenesmus. Patient may have complained that he or she, here we are talking about she, so she have frequent passage of the loose mucoid stool. So patient has to pass the stool frequently. Then patient may feel pain in the lower abdomen. It may be of variable degree. Patient may have urinary symptoms like difficulty, or even sometimes there is retention of the urine. If we will talk about the signs, these were the symptoms of the pelvic abscess. If we will talk about the signs of the pelvic abscess, so general signs, that is face is flushed, or pulse rate may be high or out of proportion. So patient may experience the tachycardia along with the high temperature, or you can say along with the fever. Per abdominal, there is tenderness and rigidity one can feel over the pelvic region per abdominal examination. A mass may be felt in the suprapubic region, which may be tender, irregular, soft, resonant on percussion. If we will talk about per vaginal examination, the vagina which is hot and tender. So per vaginal examination, as we all know, that is the two-finger examination. So our two-finger examination, so bogging and fluctuant and tender mass which is felt into the posterior fornix. So if we will do the two-finger examination, we will feel this into the why, because the posterior fornix, just behind this posterior fornix, the pouch of Douglas is situated. So uterus which is pushed anteriorly because of the collection of the pus or the abscess, and the movement of the cervix, which is actually very painful. Patient feels pain while per vaginal examination is doing. A separate mass may be felt through the lateral fornix. Rectal examination, it defines precisely the mass in the pouch of Douglas. So, in the female, if we will talk about the female organs, as we all know, the uterus lies between uterus and rectum, and in between these two, the pouch falls. While in the male, this pouch falls between the urinary bladder and the rectum. So it is termed as vesicorectal pouch. So in the male patient, if we have to do the examination, so it is done through the rectum. So rectal examination, which defines precisely, they feel the mass in the pouch of Douglas. Now, the investigation of the pelvic abscess. So what are the investigation? How we will confirm that the patient is having the pelvic abscess? So as we just go for the blood examination, routine blood examination, so high WBC count, leukocytosis, or increased polymorphs, which is suggestive of there is some infection in the body. Bacteriological study, swab is taken from the high vagina, endocervical canal, and from the pus. Now, this pus is sent for the culture for the both aerobic and anaerobic microorganisms, so one can prescribe the drug or medicines accordingly. Now, sensitivity of the microorganism to the antibiotics is also to be detected. Now, how will we confirm a diagnosis? The diagnosis is very easy in most of the cases, but at times, how it is easy? According to the history of the patient. So whether recently that particular patient has gone through some abortion, or patient has delivered some baby, or because of this puerperal condition, or because of the post-abortal condition. So according to the history, we can diagnose, we can confirm that the patient may have this pelvic abscess condition. But confusion arises between the pelvic hematocele and pelvic abscess. if there is any rupture into the fallopian tube, so which can lead to this hematocele-like condition. Blood is collected into this pouch, and if the blood is collected, accumulation of the blood takes place. Blood gets infected if it is not the treatment is not given at the proper time or the correct time, then this blood may be infected, and which can also lead to the conditions like pelvic abscess. So this confusion may arise at the time of the ultrasound. Why? Because ultrasound detects only the accumulation of the fluid, but examination under anesthesia and the puncture of the pouch of Douglas, that is the known as caldosynthesis. I regularly tell my students that the pouch of Douglas is also known as cul-de-sac. That's why this terms comes, the procedure, name of the procedure which comes from that particular word, cul-de-sac, and the procedure is known as caldosynthesis. So collection of the fluid from the posterior fornix. Needle is inserted from the posterior fornix, and the abscess or the pus is collected, and then it will be sent for the culture study. It can give the correct diagnosis. Old blood comes out in the former and the pus in the later. You can see here the procedure, caldosynthesis. Checks for the abnormal fluid in the abdominal cavity behind the uterus. You can see here with the valcellum, the uterus posterior, the uterus cervix is catched, and then the needle is inserted for the collection of this pus. Now, after investigation, we will move towards the treatment part. So if we will talk about the treatment, so general treatment here, so systemic antibiotics should cover the anaerobic as well as aerobic microorganisms. In that, the gynecologist, they generally prescribe cefoxitin 1 to 2 gram IV every 6 to 8 hours and gentamicin 2 milligram per kilogram IV per 24 hours and metronidazole 500 milligram IV 8 hours are started. Now, antibiotic regimen may have to be changed depending upon the sensitivity report or according to the condition of the patient. Next, that is the posterior colpotomy. As I told you, that is the definitive surgery to drain out the pus through the posterior fornix. And there are some loculi of the pus or bubbles, you can say, which have formed into that particular pouch because of the pus collection. So once you will drain that pus with the finger, help of the finger only, one can broke that particular loculi. So each and everything is drained out. Laparotomy. After this antibiotic application or posterior colpotomy, patient is not recovering and deterioration of the health takes place, and despite of the aggressive management, the patient may have the recurrent infection, and with the loss of reproductive function, the laparotomy is performed, and at the time the patient is suggested regarding the abdominal hysterectomy with bilateral salpingo-oophorectomy. This is the last part of the treatment. Until and unless patient has not recovery or recurrence is there, then and then the gynecologist, they suggest for this abdominal hysterectomy. Generally, they don't suggest hysterectomy or oophorectomy, as we all know about all these things. And pus should be sent for the culture and drug sensitivity test. You can see here, surgical treatment, posterior colpotomy. Can you see here? This is a cut which is given. This one, that is the uterus, and posterior to the uterus the cut is given, that is colpotomy, and along from this colpotomy pus is drained out. You can see here this one is the simspeculum, or you can see here this one is the tinea valsellum, tinea culculum. With this help of these instruments the surgery is carried out, surgical procedure. Okay, you can see here the difference between the male patient. This is according to my interest, I have just added this slide, otherwise it is not needed in this R session. So I also showed this slide in my classroom to my students also, that what male also has pelvic abscess. Male also suffers from the collection of this pus. As we talked about the extra pelvic causes. So extra pelvic causes, it may be appendicitis, it may be diverticulitis, the male may suffer. And because of this condition, or perforated peptic ulcer, if the male has some collection of the pus, at that time there is pus formation takes place over here, this region between urinary bladder and the rectum. So it is termed as recto-urinary pouch in the male. Here in the female patient, if we will differentiate both the things, so here we give cut to drain the pus into the posterior fornix. That's why it is termed as posterior colpotomy. Here drainage is done in the pus through the anterior wall of the rectum. So drainage done through the rectum. Here the drainage of the pus which is carried out through the cervix or through the vagina, posterior part. So this is the difference. Now, we are talking about the homeopathic management. Here we all are gathered for this promotion of the homeopathy. So in such conditions also, we can manage the case if it is not that much severe and we have very good results or very good drugs which gives us very good results. So list of drugs I'll show you: sepia, moxol, phosphorus, sabina, medorinum, creosote, belladonna, silicia, heparsol, sulfur, lachesis. So all these drugs which can be prescribed according to the symptoms totality, according to the condition of the patient. Sabina, if we will talk about the sabina, the sabina can be prescribed in the condition like post-abortal. Only one symptom that is given in the sabina, that the sabina is prescribed post-abortal or in the puerperal stage, or you can say recurrence abortion. So in such condition, we will think of sabina. If we will move further, the belladonna. Belladonna has very good indications actually. It is the first line of the remedy for the first stage of the inflammation, where the pus has just started to form. It is the remedy most oftenly indicated for initiatory symptoms of the abscess. There is intense throbbing pain into the pelvic region, which is actually painful. There is pressure, burning, stinging in the abscess, scarlet redness, hot swelling, pus which is scanty and flocculent, great sensitivity to cold air. Abdomen is swollen and sensitive to touch. Patient is so sensitive that the patient wants the bed clothes removed. The pungent heat of the body, it seems to be steam out on raising the bedclothes. The abdomen, especially the lower portion, which is intensely very hot. The patient is uneasy and must constantly change her position, but is made worse thereby. Next one, that is the moxol. Now, this moxol, which comes after belladonna, when the pus has formed. Here, pus is greenish in tint and quite thin and fluid. There is intense shining redness with throbbing and stinging pain. The abdomen, which is tympanitic, showing the evidence of the seropurulent matter which is present. Patient has rigors and sweat. There is rumbling in the abdomen and diarrheic stool. Frequent exacerbation fever with creeping chills and copious perspiration with no relief. So this is what about Merksol. Okay, if we will move further, next slide, that is regarding the cilicia. Now, here the suppuration which takes place and wounds, cilicia, there is one important symptom that the wound takes time to heal. That is, you can say the keynote for the cilicia, that wounds will not heal properly or not heal speedily. So we can think of cilicia. The pus is apt to be thin, watery, brownish, bloody, corroding, gelatinous, gray or greenish, putrid, and may be yellow. The process is sluggish and indolent one. Why? Because the wounds takes time to heal. It usually given often when the abscess has been opened by means of an poultice. So abscess is opened. The patient feels much better with warmth. Cilicia patient, I have not added, but the cilicia patient, as we all know, they are the most chilly patients. That's why they feels very much better with the warmth. There is much cellular infiltration about the abscess. I would like to add one thing in the cilicia, that if there is any adhesion, according to my experience, if there is any adhesion with the adjacent viscera or the surrounding organs, cilicia works very good in that condition. There is much cellular infiltration around the abscess and discharge of pus is considerably very much fetid. If we will move further, sulfur, as we know, it is a great antisoric and a very good remedy. I regularly use sulfur not for the pelvic abscess, but in many other skin conditions. It is specially useful in chronic cases where the discharge is profuse and accompanied with emaciation and fever. Chronic abscess, there is tendency to suppuration. The pus is acrid and excoriating. Pains throbbing or stinging after evacuation of the pus, and there is tendency to ulceration. It is to be thought of when the rightly selected remedy fails to give desired result. This one is my favorite symptom. I have used sulfur many times with this symptom only. And then after I got a miracle results indicated in association with the prolapses of the uterus from reaching high. Yes, prolapses of the uterus which can also lead to conditions like pus formation. And because of that, there is also collection of the pus in the pouch. Worse from the standing with the pain in the hypogastrium on the right side. Uterine pains running from groins to back. Corroding yellow leukorrhea preceded by pain in the abdomen. If we will move to the next one, that is lachesis. It is also one of the, as we know, drug picture or the deep acting medicine. It has actually very good results. It is useful where the pus is thin, dark, ichorous, and offensive. It is the remedy for the abscess where the poisonous matter introduced into the system. Fever is worse at night. The slightest touch to the surface of the abdomen, particularly the lower portion of it, which is unbearable. There is tenderness present at one point, the gangrenous tendency, which is marked under this remedy. So I have given the particular symptoms related with the pelvic abscess of some indicated remedies, not all. Now, I would like to tell you about the summary, what I have presented just now. That is the summary of the pelvic abscess. The pelvic abscess is the collection of the pus in the pouch of Douglas, characterized by spiky rise of temperature, rectal tenesmus, and lower abdominal pain. A mass is felt in the suprapubic region per abdominally and per vaginal. Examination reveals a boggy, fluctuant, and tender mass in the pouch of Douglas. The case is investigated by the blood count, USG, and cholecystosynthesis, which gives accurate diagnosis. Management part of the case possesses antibiotics regimen and posterior colpotomy, and if needed, laparotomy. We can manage pelvic abscess with homeopathic medicines like belladonna, sulfur, merxol, silicia, sabina, lachesis, etc. So, with this, I conclude my presentation and thank you everyone for listening me. So my topic gets over here.
Yes, 1 minute. Thank you, Dr. Krishna Parikh. It's really a very good session. You really covered all the aspects of pelvic abscess, and you have mentioned how it works and what are the uh, things one need to understand about this pelvic abscess and how it develop into a pro problem for a patient, and how it can be differentiated, and what are the medicine by which homeopathy can treat this. Of course, there are some cases where we need surgery, and that also you mentioned. Anyway, congratulations for such a wonderful presentation.
Thank
I
you, sir.
hope,
Thank you very much.
yeah, if you have a case to share, you can tell how you manage the case. If it just you can simply talk about a case if possible. Otherwise, uh,
Uh,
even without a presentation, you can whether you have a chance to treat such a case, and what was the outcome of the case.
Not exactly about the pelvic abscess, but I can say where I silicia used. A patient had hysterectomy, and after the hysterectomy, she had actually large fibroids. And large fibroids, because of these large fibroids, she may have the pus formation around the uterus. And after removal of the uterus, she had actually pain into the lower pelvic region on the right side. So if we will talk about the differential diagnosis, at that time, lower right side region, she may have suspect of some appendicitis, or she may have suspect some clinical condition related with the ileocecal junction. So each and everything was ruled out. Why? Because actually the uterus was removed. So they rule out, the doctors rule out all these things, gynecologist. And after nothing was there. So I started giving silicia, just 2 doses per month. But it took very much time for that. But now she has recovered 80% from that pain. So I thought ke matlab adhesion was there, and pus might be there because of the large fibroids. So silicia, I gave silicia and it gave me actually good results.
Yes, that case was really brilliant, because even with the Cilicia, you got the result in such a wonderful case. Definitely, we have opportunity to treat such cases, and and different remedies come into picture as you came into picture as you mentioned here. Those remedies are very, very important and useful in those conditions. But have you mentioned about the acid nitric? I think you
Acid
missed it.
nitric, actually, I don't have any kind of
Yes, yes, that you have
any,
mentioned.
don't have any experience of acid nitric. That's why I have
Oh,
not used yet.
okay, okay. Now it is the time for discussion, and those who want to participate in the discussion can raise your hand so that we will allow you to unmute yourself, and you can speak and ask questions regarding this particular subject. It's over to one of the leading doctor here, and he's one of the senior most doctor, Dr. Hariharan is retired from government department. Yes, sir, welcome you. Please unmute, sir.
Okay, doctor,
Yes, sir.
your class is very nice, and it needed very intelligence to treat such cases. I'm sure about it. But see, I have not much cases, but I treated one difficult case in my memory that 5 years back, a lady about 38 years came to my dispensary with pain, severe pain at the lower abdomen, and I went through the documents she brought, and I found out that she had an surgery at the for hemorrhoids, hemorrhoids at a well reputed hospital, and after that she got such a pain, and I am not much very.
পেশাবে তো তাকলিফে কি হলো পেশাব নিয়ে অনেক কিছু করতে পেশাবে তাকলিফে और पेशाब में इन्फेक्शन निकल तो गया कभी
Hello, can you hear me?
Yes, sir.
See, I am not much experience in that regard, but even then I took the case and tried several medicines according to the symptoms what she said, but in vain, and I got no result. But even then I tried, and she is compelling me to treat, and she is having such severe pain, and I gave that during that pain I will give the Macros 3x about 15 tablet, 1 grain tablet at a stretch, 15 1 grain tablets at a stretch in 2 hours interval. 2 hours interval, and she is happy, and the pain during that pain, see, if the pain comes, suddenly she will take the tablet and suddenly it will disappear. I know that the patient is not curing, but again I am probing the symptoms of that patient, and I got one PQR symptom from her. That is, I will say, I like to say, see, that is the pain. She is not getting the pain if she is having constipation during stool.
Oh, yes.
That is the PQRS.
PQRS, yes.
PQRS symptom of that patient. I gave Serena, see, from Naturopathy, I repetized, and I found out that that medicine, and I gave her the calcarea carb. Calcarea, still am I about 5 years back. I have the record with me. I think it is sure that that was calcarea carb 201 dose. Next day itself, she got relief.
Oh, great.
Right, see, from there, I raised the potency up to 10 up to 10 Now she is having no pain. She is very happy. Again, she will come to my dispensary. She is in North India, somewhere else now with her husband. And sometimes she will call, doctor, I have say, corona. I have the fever. See, she is fearing to take the allopathic medicine.
Yes.
That is cured by, I think it is calcarea carb. I want to check in my files. I will get that file, and I'm sure That was the medicine I am still remembering. This is the
Mm-hmm.
PQR symptom that I am remembering. See, so such a way I have cured only one case like that. There is no other patients come to me with retrovesical such diseases. And I like to convey this to a forum. Okay, thank you very much. So it is sure that we can cure such patients.
Yes, sir. Yes. I
Only thing,
also get some good knowledge from you, sir.
only thing is that we must probe the exact symptom and we must convert it to the rubric and find out the exact medicine. Only the PQR symptom, you take
Yes, PQRS.
that only,
Yes, sir.
it will cure.
Ah.
No doubt in that. Okay, doctor, now by you, now you remembered that case from me, and very good. Congratulations, doctor.
Thank you, sir. Thank you. Thank you so much.
Thank you. Very, very.
Thank you. Thank you, Hariham sir, coming over here and sharing your experience in that. Of course, I have also got such cases, but I used to give some additional medicines also when managing. As you rightly point out, the rectal the pelvic abscess are common in men also. The people believe that it is not only a part of women, but it can be in men also. So we have opportunity to treat both men and women in those cases. But I have to change medicines because the presentation at the time of case taking was different when because they were treated by so many people here and there, and at the time of uh, consultation, uh, the totality of the patient was different. So we will sometimes some patients are chilly, some are hot, but some are semi-thermal. But in all conditions, I used to take this as an acute condition, not as a chronic condition. So in those conditions, acute remedies are being applied. All these remedies coming, what you have mentioned about those remedies. But management of pain is entirely a different part. In those cases, I even tried arnica for that. Arnica is a very good remedy for that. As Arihan sir pointed out, a combination of Macforce with belladonna works beautifully in pain. But as we know that there's a stitching pain, stinging pain, all those things need to be considered. But the patient may simply say that, "No, doctor, I have the pain." What kind of pain? Oh, doctor, pain. How it happened? Then you may have to interact with the patient to find out whether it's a stitching pain, stinging pain, or a throbbing pain. If there is a throbbing pain, then we can definitely go ahead with the belladonna.
Belladonna.
There's no problem. Then acid nitric can come into the picture, and sometimes patient may say that, doctor, I have the pain soon after passing the stool. It is very difficult for me to pass stool because of this. All these things happen after the surgery to some part, either as you point out in appendicitis or after the piles, the hemorrhoids, like that. So in all those conditions, we will have to take the case in detail and find exactly what remedy exactly come into the picture. And of course, the diet is also a very good thing. It is better to manage with the protein diet in those conditions when the wound is not healing properly. So after giving medicine, usually I used to advise them to take either fish, certain kind of fish, uh, particularly shark is a very good remedy, fish for that. Then the egg of duck, not chicken. Sometimes the egg of chicken will do much damage than good. That's what I have noted. In those cases, I used to ask them to try to find some egg of duck that won't do any harm, but it will give better, easy healing of the abscess. So these are as well as we can ask the patient to take as much of water and pass as much of urine. so that some of the waste can be eliminated, as well as try to avoid constipation. So we can advise some fruits regularly. Either banana. Banana means the big banana is making more trouble, but a small type of banana. I don't know how to differentiate the name for that. We used to say and there are different type of bananas, but the big one is the troublesome for those particularly for the people who are having hemorrhoids or piles or fissure, all those things that will make trouble. But the small type of bananas are definitely the category, both are different. The big one can produce more constipation, but the other one, which is very soft and which may not do much harm, but it will do more good to eliminate the stool easily. So eliminating the stool itself will may give some kind of relief to the pain of the pain in the abscess. If there is a large quantity of stool remains in the rectum, the pain will be worse. So also you can see in ladies also during the time of menses, sometimes this pain may aggravate, or sometimes it may relieve. So that may be that may vary accordingly. So in that case also we will have to differentiate what is that we can consider that as a very a characteristic, because if there is a remove pain, if there is no pain during menses in the abscess, then that is a very good symptom. Then we can repertorize in that way, like that. So as a homeopath, we will have to look into all aspects of this case. Simply don't think that it's a case of anal abscess or this pelvic abscess, and we have these remedies. But don't think in that way. But we will have to think it in a broader way, and then definitely we will be able to conquer them. I am inviting Dr. Anita Soman to say a few words on your experience. Dr. Anita Soman. Can you say what are the medicine according to you the best? Yes.
I don't have much experience about pelvic abscess. I don't have so much case and not much cases about pelvic abscess. But one case that I have given pyrogen 200. It's very effective that for that patient. It was very effective and completely cured with the pyrogen 200. Not much experience.
Yeah, that itself is a good thing, because that's a very rare prescription indeed. People may think in a broader way, but you come up with the pathology. Pathologically, it's a
Yeah, it is
pathological disease.
pathologically I prescribed that. That's
Yes.
the patient is having that severe fever patient. That is septicemic condition that
Yes.
happened. So I prescribed that pyrogen.
Okay,
It's
that's
the patient was completely recovered from that condition.
okay. That's a very good, very good information, and very good mode of selection also. That's we have different type of prescription. We can go with acute prescription, for this pathological prescription, then constitutional prescription, whatever may be. We need to get the result. That is what a homeopath need to look into. And now I invite Dr. Rambaresh sir. He is also another person in this field.
Thank you, Dr. Dhaneji, and pranam everyone. Dr. Senior Homeopathic Physician Hariharan sir, and congratulations, Dr. KRISHNA Parikh. Very good describe the pelvic abscess.
Thank you so much, sir. I'm really obliged.
Cause, effect, and treatment in homeopathy. लेकिन angle of treatment, according to angle of treatment, according to law of homeopathic science, first angle, symptomological angle. only for acute disease. Select remedy and very quick action, homeopathic medicine. Second, pathological angle, test, etc. Third, miasmatical angle, according to law of homeopathic science. Without miasmatical angle, not cure the chronic cases. Chronic cases, teach the curative way of treatment according to miasmatical angle. Yes, Marksol, sulfur. Sulfur is a very good mother of any disease. So, king of antisoric remedy is called name of sulfur, and queen of antisoric remedy is called name of sorinum. King of antisyphilitic remedy is called name of Marksol, and queen of antisyphilitic remedy is called name of syphilinum. And king of antipsychotic remedy Thuja, and queen of antipsychotic remedy Madorinum. So according to miasmatical angle, Marksol is a very good pelvic abscess. Silesia is a very good remedy. Sulfur is a very good remedy. Belladonna, very good remedy, pelvic abscess. There are bod. Belladonna is called name bod. B say burning. I say inflammation. R say red. And D say delirium. And throbbing pain, etc. So very thanks Dr. Krishna Parikh and हमारे senior physician Dr. Hariharan sir. Very
Okay,
nice
sir.
presentation, Krishna Parikh.
Thank you so much, sir.
Thank you.
I'm
Now,
really obliged and thankful to all of you
now
for
I invite,
giving me such an opportunity and also making my confidence high.
now I invited Dr. Mas to say the vote of thanks to the session. Dr. Mas from Malaysia.
Thank you, Dr. Dinesh. Actually, I came in quite late, but I managed to listen to the final part of the session, which was very interesting. I'd like to thank Dr. Krishna for the insightful sharing, which is very beneficial, and look forward to hearing more from you soon. Thank you very much.
Thank you. Wow, very good.
Thank you, Dr. Mas. And tomorrow we will have a session from Dr. Veeran Nimag. He is the Associate Professor, Department of Surgery, Rajkot Homeopathic Medical College, Gujarat. And we'll be talking about urolithiasis and its homeopathic management. So another big day is coming tomorrow. So hope all of you will be with us at the same time. Thank you all for joining the session. Once again, thank you, Dr. Krishna Parikh, for your excellent presentation. Thank you all. It's over to Dr. P. Shaila to moderate the Malayalam session.